Okay, so to understand the lesions, we need to understand how the tracts are passing, where they're coming from, where they're going. That is very cardinal, so that when they tell us that okay, a person on a motorbike accident injured themselves in this specific area, we would easily see the clinical manifestations. So here we have the starting point, which is a precentral gyrus. So the precentral gyrus is serving as a motor unit of the cortex, meaning that the postcentral gyrus is going to be a sensory unit. Okay, so pre is motor and then post, that is sensory. So it's starting from the precentral gyrus and then it's coming all the way down into the posterior limb of the internal curve. So it goes down to the midbrain, to the pons, and then finally in the medulla we see some decusations taking place. But this is specifically the pathway of the corticospinal tract, but we're just using it to understand that other tracts might also use the same path. For example, the corticobulbar or the corticonuclei. These guys use a similar path. Or those ascending ones, those starting from the spine and going to the cortex, talk of the spinothalamic. Yeah. So upon having this, we need to look at each level. So we start with the cortex, and then we go to the internal capsule, we'll go to the midbrain, we go to the pons, we go to the medulla, and then finally we're going to reach the spinal cord. So stick around for each of these segments. And so when we start with the cortex, we're going to understand that the precentral gyrus, which is the motor division of the cortex, is going to be divided into these regions. So there's going to be a region in the cortex that is responsible for controlling motor functioning of the leg. There's going to be a region in the cortex that is responsible for hip and trunk movement, and there's going to be another one for the arms and the hands and another one for the face. So if you were to cut it like this and then look at it from this view, we would have something like down here. So you're having the leg part being medial. So being medial, this means that this is the cortex. So there's another cortex that's supposed to be this side. So this part here is the medial part, and then this side here is the lateral part. So if this is your head and then these are your eyes, it's like we've split you in half like this, and then we are seeing it from the sides here. So we are saying that here where we've split it in the middle, yeah, and then all right, so we're not seeing it from here, we're just actually seeing it from the front. So if we're seeing it from the front, this side here is going to be the medial, and then this side here is going to be the lateral. So the leg, motor movement of the leg and the foot, followed by movement of the trunk, a movement of the arm, and then finally movement of the face. So in terms of the lesions, what we're interested in is the anatomical terminology that is going to be used. So if they tell you that, okay, this patient comes to the hospital and presents with a history of a lesion on the medial side of the right cortex. So you're going to understand that if I have my brain like this, my brain is split into two, where there is left and right. So if I have my left and right, both my left and the right have their medial sides, and they also have their lateral sides. So if they say the medial right, then the medial right should be this side here. Yeah, so meaning that manifestations such as paralysis are going to be on the opposite side, because we know that the right side of the brain controls the left side of the body, the left side of the brain controls the right side of the body. In short, these things are contralateral. So any cortex lesion that you're going to have always presents contralaterally, but the only thing that's going to guide you is the level of lesion. Is it medial? So if it's medial, it has to damage the legs. If it's lateral, if it has to damage the face. If it's middle, so if it's a middle lesion of the cortex, then it has to damage the arms. Okay, so in spite of it being medial, damaging the legs, lateral, damaging the arms, is what you call a partial lesion and a complete lesion. So when they say a partial lesion, so partial lesion is basically just restricted to that area that is responsible of motor movement. So let's say a partial lesion of the medial cortex, meaning that we're going to have mainly leg paralysis. But when they say a complete lesion, a complete medial cortex lesion, then we're going to have leg paralysis coupled with some arm paralysis somewhere there and some trunk paralysis. So it's going to be a mixture. But so this is what we have in the cortex. And then from the cortex we can move to the next part, which is the internal capsule. Your corona radiata. So your corona radiata is actually just a fan of these fibers or these neurons coming from the cortex. So they're coming from the cortex and they're coming down in this manner. Now since the cortex is subdivided, meaning that even the neurons that are coming from it are also divided likewise. So this is why we have them. So these guys being for the face, these guys being for the arms, these guys being for the trunks, and these guys being for the legs. So if they tell you to say, okay, we have an anterior lesion, so here we're looking at it from the top view. So if this is your head, these are your eyes, we've cut you like this, then we're looking at you from the top. So if they tell you to say, okay, this person has, so this part is the anterior, this part is the posterior. This part is anterior, posterior. So the anterior lesion mainly damaging the face. Posterior lesion mainly damaging the legs. Yeah, but if they tell you to say it's a complete anterior lesion of the corona radiata, then not only the face is going to be affected, but of course we're going to see the arms being affected as well. If they tell you it's a complete lesion of the legs, then not only of the posterior part of the corona radiata, then not only will the legs be affected, but also the trunk and the hip. And to some extent, even the arms, depending on the severity of the lesion. But basically, that's what you're going to have with these two segments. So this is another view where we can see these guys from. So this is the precentral gyrus, meaning this is the cortex. And then from the cortex, we're going to have neurons going down to the spinal cord, neurons going down to the spinal cord. But these neurons come down in a crown-like radiating manner. Hence, we're calling it corona radiata. So this section here is a corona radiata. But when these corona radiatas come to converge here, they come to form what you call the internal capsule. And this internal capsule has parts. So it has the posterior limb, it has the genu, and then it also has the anterior limb. So mainly when it comes to our corticospinal tracts, our tracts of the spinal cord, they travel in the posterior limb. So looking at it from a different view, from a horizontal section of the cerebral hemispheres, this here is going to be your internal capsule. So this is the posterior limb and this is the anterior limb. So we're saying that in the posterior limb, that is where the descending tracts pass through. So meaning that we'll only have motor manifestations in a patient if they have a lesion in the posterior limb of the corona radiata, not the anterior limb, but the posterior limb. So we have it being like that. Now, let's also remember that the corticospinal tract is not the only tract that originates from the cortex. There's another tract that originates from the cortex and descends down, another descending tract. So that tract is what you call the corticobulbar tract. So with the corticobulbar tract, we see that this guy goes to the nuclei of the cranial nerves, the nuclei of the cranial nerves. So we get to see that if this is your cortex, so let's say this is your cortex, your tumor spindles are going to come here, come down here, reach somewhere in the midbrain, if it's in the pons of the medulla, and then it's going to go to the different nuclei of various cranial nerves. So each cranial nerve from 1 to 12, they have their nuclei where they originate from, and these nuclei are located in various positions. They're not all at one point, in various positions. So depending on where the lesion is, it might affect one cranial nerve because that nuclei of that cranial nerve is in the area of the lesion. So we're going to be seeing more of that as we go to the pons and the medulla and the midbrain. So, but what I'm interested in here is what you call the corticobulbar tract. Corticobulbar tract originates from the cortex, passes through the corona radiata, passes through the internal capsule, just like the corticospinal tract. But this one doesn't reach the spine. It reaches in the pons and in the medulla to the nuclei of the cranial nerves. So of our interest is cranial nerve number 7, which is the facial nerve. Now this cranial nerve number 7 its nucleus is found at the junction of the pons and the medulla. So you have the pons on top and we have the medulla down, and then imagine your nuclei for the cranial nerve being in this fashion. Okay, so there are two nuclei, one for the left side, one for the right side, and both of these nuclei are separated. There's a portion in the pons and then there's a portion in the medulla. So what happens is that your corticobulbar tracts can originate from the left side of the cortex. They can also originate from the right side of the cortex. So the ones on the left side of the cortex, they come and innervate this guy. They're also going to come and innervate. All right, let me just depict it on this diagram here. So on this diagram here, we're seeing the corticobulbar tract, and on this corticobulbar tract, it is starting from the left side, and then it is decussating here and going to the right side, two of these nucleuses. So we said of these nucleuses, we're mainly concerned about the facial nerve there because it does have a peculiar feature where the left side is only touching the superior portion of the facial nucleus, the pontine portion of the facial nucleus, whereas this one coming from the right side is going to touch both the pontine and the medullary portion of the facial nucleus. And same thing on this other one, uksok, right uksok. So this one from the left is touching both the top and the bottom, but the one on the same side is only touching the top. So the key thing that you must get out from here is that the facial nucleus is divided into two, the superior portion and the inferior portion. So the superior portion receives two fibers, one from the left and one from the right. The inferior portion just receives one fiber, and which is the one from the opposite side. The one from the opposite side. So if we have a lesion, so let's say we have a lesion, and then this lesion is specifically uksok side ukso, you're going to see that the one that's going to suffer is the inferior part of the opposite side. Why? Because the side of the lesion, this left side, it is the only one providing innervation to the bottom part of the right side. Same thing, if you have a lesion on this side, the side that's going to suffer is the bottom part here. And that's why we are seeing this one here. Okay, but when we have a lesion across like that, then the entire muscle is going to be disturbed and stuff like that. So this is what we're going to be seeing even as we look at the internal capsule. So the internal capsule. So if they tell you to say, okay, the posterior limb of the right side of the internal capsule has been injured, how do you expect your presentation to be? So we expect that, so let's say, so the right side of the internal capsule, how do you expect the lesion to be? So if this is the common person, I know for a fact that if the right side is affected, then the corticobulbar tract on the left side, the left bottom part is going to be affected, whereas the left side of the entire body is going to be paralyzed as well. So this one here for the face is from the corticobulbar tract. This one here for the body is from the corticospinal tract.